My name is Rob Simon from the Cleveland Clinic. I'm going to be talking about benign disorders of the pancreas, particularly acute and chronic pancreatitis. So pancreatitis is a wide spectrum of a disease. It can range from a self-limited course where the patient has minimal impact on their life to a severe episode where the patient develops organ failure and even death. This talk is going to focus on two aspects of the disease, acute and chronic pancreatitis. I have nothing to disclose. So again, like I said, pancreatitis is a wide spectrum of a disease. We're going to cover all types of pancreatitis in this talk. This includes acute pancreatitis. We're going to talk about some definitions, some clinical assessment tools, a little bit on management. We're then going to move into a subset of acute pancreatitis called necrotizing pancreatitis. We're going to talk about infected and non-infected necrosis, as well as management of this. And then we're going to talk about another rare type of pancreatitis called groove pancreatitis. We're going to touch a little bit on presentation as well as management. And then finally, we're going to talk about the tough diagnosis of chronic pancreatitis, looking at some definitions, a little bit on etiology, and again, touching on management. So first up is acute pancreatitis. So in general, pancreatitis is inflammation of the pancreas, but in actuality, it is much more than that. It's a wide spectrum of a disease, as we have mentioned before. I just want to reiterate, but it's important to understand the language. First up, in order to diagnose somebody with pancreatitis, they have to meet two of the following three criteria. So they have to have acute onset of epigastric pain that plus or minus radiates to the back, classic abdominal pain consistent with pancreatitis. They have to have imaging findings that are consistent with pancreatitis, or lipase levels measured in the serum that are greater than 3 times the upper limit of normal. Some physical exam findings that have been described are Cullen sign, which is bruising in the periumbilical region, and Gray-Turner sign, which is bruising in the flanks. The way to remember these are that Cullen is one word and you have one umbilicus, and Gray-Turner is 2 words and you have 2 flanks. These are uncommon physical exam findings that are indicative of hemorrhagic pancreatitis, but are among some of the favorite pimping questions to keep in mind. Patients can have interstitial edematous pancreatitis, where there is peripancreatic fat stranding and the entire pancreas is viable. The patient can also have necrotizing pancreatitis, where part or all of the patient's pancreas is not viable and has actually become necrotic. These definitions are particularly important when we talk about fluid collections around the pancreas. In early interstitial edematous pancreatitis, the fluid collections are called acute peripancreatic fluid collections. And in late interstitial edematous pancreatitis, they are referred to as pseudocysts. Once the patient has been diagnosed with necrotizing pancreatitis, you cannot use these terms anymore. Instead, you have to use acute necrotic collections for early fluid collections and walled-off pancreatic necrosis, or WOMPN, for late fluid collections. The 4-week cutoff for early versus late is typically the time frame it takes for a fibrinous rind to form around the fluid collections. This allows interventions to be more successful. These are some examples of cross-sectional imaging appearance of pancreatitis in various pancreases. On the left is an example of interstitial edematous pancreatitis. You can see the entire pancreas enhances, and there's some fat stranding and edema around the pancreas. Compare this to the image on the right that represents necrotizing pancreatitis. On contrast enhanced cross-sectional imaging, part of the pancreas does not enhance with IV contrast. You can actually see the tail of the pancreas enhancing and leading right into the fluid collection, where there is an abrupt cutoff and no more pancreas that enhances. The percentage of pancreas that becomes necrotic can be approximated based off of how much of the pancreas is hypoenhancing compared to the normally enhancing pancreas. So there are a variety of etiologies of pancreatitis. The two most common are cholelithiasis and alcohol. In addition, smoking is a known risk factor for pancreatitis. You can have autoimmune pancreatitis. Hypercalcemia can cause pancreatitis, as can hyperparathyroidism, usually from the hypercalcemia. Hyperlipidemia. There can be masses that obstruct the pancreatic duct and cause pancreatitis. You can also have pancreatic divisum. Diet and obesity are also being looked at as suspicious for causes of pancreatitis. Now, a pancreatitis talk would never be complete without discussing scorpion bites. Not all types of scorpions cause pancreatitis. The bark scorpion, for example, in the southwest United States, is the most venomous scorpion in the United States. It causes pain and paresthesias in the area of the body that it was stung, but it does not cause pancreatitis. The two scorpions that have been studied and proven to cause pancreatitis are scorpions from Trinidad and Brazil. Titius trinitatis is the predominant scorpion in Trinidad, accounting for approximately 90% of scorpion bites on the island. A study out of the 70s looked at 30 scorpion stings by this type of scorpion, and of the 30, 24 developed acute pancreatitis soon after the sting. They all developed simple, acute, uncomplicated pancreatitis and had an uneventful recovery. Of note, 6 of the 30 patients were able to actually kill the scorpion after it bit them and bring it into the hospital with them to confirm the diagnosis. The Brazilian scorpion was actually studied in the lab, and the etiology behind it causing pancreatitis was that it inhibits vesicle transport of the pancreatic enzymes out of the cells, therefore they're activated in the cells and cause pancreatitis that way. Much of the management of necrotizing pancreatitis is dealing with the complications. This includes recognizing and treating the end organ failure, infections, ARDS, etc. There are multiple clinical assessment tools that try to predict the severity of the acute pancreatitis episode. Ranson's criteria is used. This is a classic clinical assessment tool. The problem is that you need to collect data at 2 time points, one on admission and one at 48 hours. The data points collected at admission are age, white blood cell count, glucose, LDH, and AST. The 48-hour data points are hematocrit drop greater than 10 points, BUN increase greater than 5, calcium less than 8, PaO2 less than 60 millimeters of mercury, a base deficit greater than 4, and fluid sequestration greater than 6 liters. Another clinical assessment tool that's been described in the literature is the Apache 2 criteria. This one is cumbersome. It requires a history of severe organ failure, age, temperature, mean arterial pressure, pH, heart rate, respiratory rate, sodium, potassium, creatinine, acute renal failure, hematocrit, white blood cells, Glasgow Coma Score, FiO2. Now, this has been shown to help predict mortality, but as you can see, there are a lot of data points. This brings me to the next clinical assessment tool, the BISAP score. This is the bedside index of severity in acute pancreatitis. This one's meant to be easy to calculate and used at the bedside. We use this at our institution to help determine if the patient needs to be admitted to the medicine service or the surgery service. The reason being that if the patient has more severe disease, they are more likely to need a procedure, and therefore we prefer to admit these patients to the surgical service. The BISAP score is made up of BUN greater than 25, abnormal mental status with a Glasgow Coma Score less than 15, evidence of SIRS greater than 60 years old, and evidence of a pleural effusion. A score of 0 to 2 is low mortality of less than 2%, A score of 3 to 5 is associated with a higher mortality of more than 15%. Therefore, again, we use a score of 3 to 5 to require surgery admission. There are many downsides to using these clinically. For example, Ranson's criteria requires multiple days to calculate. Both the Ranson's and Apache 2 are complicated with lots of variables that are hard to memorize and implement, and many forget to order the labs necessary to even calculate them. At the end of the day, it's important to just keep a close eye on these patients and assess if they are showing signs of clinical deterioration. Besides end organ failure and a significant SIRS response, direct complications of pancreatitis can occur and include pseudoaneurysm formation, splenic vein or portal vein thrombosis, pancreatic ascites, fistulas between the pancreas and the thorax, or even the pancreas and the surrounding bowel. In order to manage these patients appropriately, you have to be aware of the possible complications and know what to look for. Therefore, if a patient's hemoglobin drops, you need to be paranoid and look for evidence of pseudoaneurysm formation or evidence of hemorrhage into a fluid collection or around the pancreas. The big thing about managing patients with pancreatitis is nutrition. Multiple studies have shown that enteral nutrition is far superior than TPN, and especially better than no nutrition. It is safe to feed patients with acute pancreatitis if the food and the PO intake make the pain worse, then stop and place a nasojejunal feeding tube. This can often bypass the pancreas and allow the patients to get good enteral nutrition without exacerbating their pain and causing worsening of their pancreatitis. If this still causes an increase in pain and the patient is not tolerating it, then TPN is warranted. But in the vast majority of patients, enteral nutrition is well tolerated and results in better outcomes. The other thing to consider is a particular subset of patients that have gallstone pancreatitis. In these patients, a cholecystectomy should be performed prior to them leaving the hospital. This is in an effort to try and minimize the chance of them coming back with another episode of pancreatitis before their gallbladder can be removed. Also of note, patients sometimes need an endoscopic retrograde cholangiopancreatography, or an ERCP, prior to cholecystectomy if the stone is still stuck in the common bile duct. Patients with necrotizing pancreatitis fall into the category of severe acute pancreatitis. It is important to recognize early signs of organ failure, as a significant amount of patients with organ failure end up developing necrotizing pancreatitis. Necrosis of the pancreas can range from a small amount of the pancreas to near total necrosis of the gland. This leads to dysfunction of the gland and often requires insulin and/or pancreatic enzyme supplementation. Again, it's important to determine which type of pancreatitis a patient has. For patients with necrotizing pancreatitis, they can have acute necrotic collections if there is a peripancreatic fluid that is less than 4 weeks old, and walled-off pancreatic necrosis, or wampin, if the fluid collections are greater than 4 weeks old and have a rind around them. Just to reiterate, you cannot use acute peripancreatic fluid collections and pseudocysts to describe patients that have necrotizing pancreatitis. Something to consider in these patients is that due to the fluid shifts and large amount of IV fluids that these patients often require, they are at risk of developing abdominal compartment syndrome. Intra-abdominal hypertension is measured by using a bladder pressure monitor. This is a special Foley catheter with a pressure probe integrated into it. The patient is to be laid flat in order to get an accurate measurement. The bladder should be filled with no more than 25 cc's of fluid, and one should wait approximately 30 to 60 seconds prior to taking a measurement to allow the detrusor muscle to relax. An intra-abdominal pressure greater than 12 millimeters of mercury is determined to be abdominal hypertension. The diagnosis of abdominal compartment syndrome is a clinical diagnosis. There's no set pressure that one requires to be diagnosed with abdominal compartment syndrome. The clinical criteria for abdominal compartment syndrome is that the patient is difficult to ventilate due to the pressure on the diaphragms, making it difficult to ventilate the patient. Decreased urine output is another criteria from the pressure in the abdomen causing an obstructive acute kidney injury. And hypotension also develops because of compression of the IVC causing decreased venous return to the heart. Patients that develop abdominal compartment syndrome can be treated non-surgically with diuretics, although they usually don't tolerate these because they are requiring so much fluid from the distributive shock and hypovolemia that they're in. Patients can also be paralyzed as well to help relax the abdominal musculature and make the abdomen more compliant, thereby reducing the intra-abdominal pressure. If these measures do not work and the patient continues to have abdominal compartment syndrome, then a decompressive laparotomy is required, and the patient's abdomen should be left open with a temporary closure device to allow for the abdominal pressure to decrease. Approximately 30 to 40% of patients with necrotizing pancreatitis will develop infection of their pancreatic necrosis. It usually occurs in the second or third week of their disease course. Secondary infection of necrotic pancreas is an indication for a procedure to drain it in order to obtain source control. This can be performed in many different ways. The first step, though, is determining whether or not the walled-off pancreatic necrosis is infected or not. This includes looking at the clinical picture of the patient. Are they febrile? Do they have a leukocytosis? Are they developing signs of sepsis? A change in clinical picture warrants repeat imaging, and if there are gas bubbles in the fluid collections, that would suggest secondary infection. If there is question, an FNA can be performed, either percutaneously via radiology or endoscopically using ultrasound guidance. The cross-sectional imaging will also help you determine which method of draining will be most appropriate or effective in the particular patient. It should be noted, though, that infected walled-off pancreatic necrosis should not be thought of as an abscess, because an abscess is purely fluid that can be easily drained with a catheter, whereas infected walled-off pancreatic necrosis has lots of debris in it. This will over time liquefy, but in the acute setting, drains are unlikely to be enough and often need some sort of debridement. If the walled-off pancreatic necrosis is located posterior to the stomach, then a cystgastrostomy is appropriate. As you can see in this image, the area of walled-off pancreatic necrosis has gas bubbles in it, suggesting infection. It is also abutting the posterior wall of the stomach and is in good position for a cystgastrostomy. You can also see a nice capsule around the fluid collection so that you know it is a late finding and is amenable to drainage. Cystgastrostomies can be performed endoscopically, laparoscopically, or open, the method of which depends on the comfort level of your endoscopist at your hospital as well as your surgeons. Cystgastrostomies can be performed endoscopically by advanced endoscopists. They use an endoscopic ultrasound to visualize the area of walled-off pancreatic necrosis. They ensure that there is no vasculature going into them or no pseudoaneurysms. They then insert a needle into the collection and use guide wires and balloons to widen the gastrotomy. They use a large double-flanged metal stent, as you can see on the bottom of this slide, that are placed to keep the tract open and help facilitate debridement with the endoscope. The endoscope can easily be passed through this multiple times to debride the cavity, usually using graspers or baskets. They usually require multiple debridements over the course of weeks to fully debride the cavity. It should be noted that when the stent is not being used anymore, when the cavity is completely debrided, the stent should be taken out to prevent further complications from the stent, either migration or eroding into surrounding structures. A cystgastrostomy can be performed laparoscopically or open by making an anterior gastrotomy. Use an ultrasound to find the area of walled-off pancreatic necrosis. And then you make a posterior gastrotomy over the collection, and you fire a GIA stapler to enlarge the opening and facilitate debridement and irrigation of the cavity. A step-up approach can also be performed. As you can see in this image, compared to the other one prior, it does not have a very big component abutting the stomach. There's more heading towards the paracolic gutter and the splenic hilum. This makes it difficult to reach in a cysgastrostomy and would be more amenable to percutaneous drainage with the potential for a step-up approach. The step-up approach is a method that was popularized by the Dutch Pancreatitis Study Group after they released a randomized multi-center study in 2010. They were comparing the step-up approach to an open necrosectomy. The step-up approach was found to have a lower mortality rate and lower rates of complications compared to open necrosectomies. This involves percutaneous drainage of the walled-off pancreatic necrosis with serial catheter placements with larger and larger catheters. Once the catheter tracts are well formed, they can be removed in the operating room, and the tracts can be followed into the cavity using laparoscopic cameras and instruments to help facilitate the debridement. This is termed video-assisted retroperitoneal debridement, or VARD, and occurred in a median of 10 days after percutaneous drainage. This avoids large laparotomy incisions. The mortality rate was no different between the two groups, but there was a significant amount of patients that required an open necrosectomy despite getting a VARD, suggesting that the VARD was not able to adequately debride the infected necrosis. The step-up approach has been shown to be a safe option in the correct patient, but oftentimes it should be noted that patients may require an open necrosectomy later just to ensure that the cavity is adequately drained. Finally, an open necrosectomy is the gold standard for pancreatic debridement in affected pancreatic necrosis patients. This is indicated if the walled-off pancreatic necrosis is too large and too extensive to be drained via the other two methods, or if the patient is too sick clinically and needs source control rapidly. This involves a large laparotomy incision, either via a midline incision or bilateral subcostal incision. The cavities are entered either via the gastrocolic ligament or the transverse mesocolon, and the necrotic tissue is bluntly debrided. The cavities are then copiously irrigated, and large drains are left in place to help with irrigation postoperatively and to aid in collapse of the cavities from the inside out to avoid reaccumulation of infection. These pictures are an example of some of the debrided tissue that one can get out from an open necrosectomy. You can see why this would be difficult via percutaneously placed catheters or the other methods described. Groove pancreatitis. So groove pancreatitis is a rare form of pancreatitis. It is focal chronic pancreatitis. It is located in the pancreatic tissue between the medial wall of the duodenum and the intrapancreatic bile duct, also called the pancreatico-duodenal groove. Usually found to have both solid and cystic components. Likely requires both genetic predisposition from ectopic pancreatic tissue in the duodenal wall combined with environmental factors, for example, alcohol and smoking. Almost all of these patients that are found to have groove pancreatitis drink alcohol and smoke. These patients can present with obstructive jaundice and gastric outlet obstruction. The inflammation around the duodenal wall and the pancreatico-duodenal groove can irritate the duodenum, cause stenosis, and lead to a gastric outlet obstruction. Also of note, in these patients, you need to rule out a malignancy. Getting a CA19-9 and an endoscopic ultrasound is helpful with this. As you can see in this patient, there is some inflammation in the pancreatico-duodenal groove, circled by the red arrow. In order to properly manage these patients, it is imperative that they stop smoking and stop drinking if there is any chance for this to improve. The nutritional support is also a key part of the management. It's tricky in these patients because they often have gastric outlet obstruction, making it difficult for them to tolerate much PO intake. Therefore, nasojejunal feeding tubes can be placed, and if needed for a long period of time, percutaneous gastrostomy tubes with jejunal extensions to get past the duodenum are also very helpful to supply good enteral nutrition for these patients. This is a form of chronic pancreatitis, though, and so fibrosis does occur. Sometimes the inflammation improves, but the fibrosis causes persistent scarring and stenosis of the duodenum and or the bile duct, causing persistent gastric outlet obstruction and persistent biliary obstruction. They often have persistent pain as well. Therefore, the patient may require surgery to improve their symptoms. If surgery is required, a pancreaticoduodenectomy is usually performed. Of note, the timing of this is important because you don't want to do it in the setting of acute inflammation. You want to get them out far enough from the inflammation before doing it to make the surgery easier. Therefore, again, nutritional support is imperative. Lastly, we're going to talk about chronic pancreatitis. It's a difficult disease to manage. It's a rare entity, but has significant impact on those individuals involved. It's been associated with a decreased life expectancy of about 10 to 20 years and a significant decrease in the quality of life as well. Here are some definitions that we need to discuss. First, recurrent acute pancreatitis is different than chronic pancreatitis. Recurrent acute pancreatitis is defined as at least 2 episodes of pancreatitis with documented enzyme elevation at least 3 times the upper limit of normal, but it is not necessarily chronic pancreatitis. Chronic pancreatitis causes irreversible damage to the pancreas. There's a group of specialists from around the world who met in Chicago, Illinois in 2007 at the Rosemont Hotel by O'Hare Airport. The primary objective of this group was to develop a consensus guidelines to diagnose chronic pancreatitis using endoscopic ultrasound. They wanted to standardize the diagnosis. They implemented stricter definitions that included checklists to help reduce inter-observer variability. They also got rid of the binary yes-no grading system and replaced it with a 4-level system to stratify the likelihood of chronic pancreatitis: normal, indeterminate, suggestive, and consistent. It is a complicated list, and I'm not going to go over all the details at this time. Now we're going to talk about some of the most common etiologies. We didn't go into too much detail before in the acute pancreatitis section, so we're going to go into a little bit more detail now. First of all, alcohol is thought to be the etiology in about 70 to 90% of cases of chronic pancreatitis. This is thought to be dose dependent, requiring about 60 to 80 grams of alcohol per day, equating to about 4 to 6 drinks per day. It's also thought that it requires repeated exposure for a minimum of about 6 years. Alcohol is metabolized by the pancreas, and it is thought that the metabolites of the alcohol injure acinar cells. Seeing as not all those who drink large amounts of alcohol on a regular basis develop chronic pancreatitis, it is thought that there must be another contributing factor, such as genetics. Some genetic mutations have been identified in chronic pancreatitis that alter the chymotrypsin C gene and can predispose the pancreas to activate trypsinogen prematurely. Smoking definitely sensitizes the pancreas to the toxic effects of alcohol. It has also been shown to be an independent risk factor in and of itself, and felt to be dose dependent, with no increased risk in those with a 10-year pack-year history of smoking. Those with a 15 pack-year history of smoking, chronic pancreatitis was diagnosed 10 years earlier, and 76% of those with a 20 pack-year history of smoking were found to have chronic pancreatitis. If a patient does not drink alcohol or smoke, it can be quite challenging to identify an etiology for their chronic pancreatitis. Hereditary testing can be performed to help identify one of the many gene mutations thought to contribute to chronic pancreatitis. In addition, autoimmune pancreatitis can occur, and IgG4 should be checked in individuals. These patients have been found to have upregulated autoantibodies to trypsinogens. In addition, they have complement and IgG4 around pancreatic ducts and acinar cells. There are two types of AIP, or autoimmune pancreatitis. Type 1 typically occurs in older individuals with a mean age of 62 and are identified as having elevated levels of serum IgG4. They are also found to have lymphoplasmacytic infiltration and IgG4 on pancreatic biopsy. Oftentimes, patients are found to have other fibroinflammatory diseases. The mean age of type 2 patients is 40 to 48 years of age and is often found in patients with inflammatory bowel disease. These patients do not have elevated IgG4 levels, nor do they have other extrapancreatic fibroinflammatory diseases. On pathologic examination, they are found to have granulocytic epithelial lesions. Interesting side note, cassava was once thought to be a risk factor for developing chronic pancreatitis, but in study in rats who were fed cassava for up to a year were not found to have developed chronic pancreatitis. In addition, observational studies found that multiple areas with high cassava consumption were not noted to have increased rates of chronic pancreatitis. Also, similar to acute pancreatitis, hypercalcemia, hyperparathyroidism, hyperlipidemia can also be associated with chronic pancreatitis, as can various diets and obesity. So the pathophysiology of chronic pancreatitis is complicated, but it usually starts when the cells are damaged by an inciting factor, such as alcohol or smoking, that causes apoptosis and necrosis. The cells release cytokines and growth factors that are then phagocytosed by macrophages. This causes more cytokines to be released, which then leads to activation of the pancreatic stellate cells and fibroblasts. These then activate the extracellular matrix, which replaces the normal architecture of the pancreas. This can be a vicious cycle, because the PSCs are thought to enhance fibrogenesis by decreasing the amount of collagen breakdown. Therefore, even after the inciting factor is stopped, fibrosis can continue to occur. Of note, the fibrosis is irreversible. This can lead to exocrine and endocrine insufficiency due to the loss of the islet cells and acinar cells being replaced by the fibrosis. The initial inciting factor can vary, but most commonly is associated with alcohol, as we discussed before. So the clinical presentation, again, this is irreversible damage to the pancreas that can lead to not only chronic pain, but also irreversible endocrine and exocrine pancreatic insufficiency. The abdominal pain is tough to control. Patients are often requiring narcotics. It is important to help patients by getting them to pain management and pain psychologists to help them manage their pain with non-narcotic options. These can include endoscopic ultrasound celiac plexus blocks, where local anesthetic is injected into the celiac plexus to help with their pain. This can include other sorts of meditation and psychology evaluations. Exocrine pancreatic insufficiency requires pancreatic enzyme supplementation. Diabetes mellitus can also occur, requiring lifelong insulin. And again, these patients often present and describe a decreased quality of life due to their pain and other comorbidities. Tumor markers are helpful to differentiate pancreatitis from cancer, because sometimes it's difficult to tell based off of cross-sectional imaging. Of note, these should not be ordered if the bile duct is obstructed, as this can lead to abnormally elevated levels. IgG, in particular IgG4, is helpful to look for autoimmune pancreatitis. Lipid panels, calcium levels are helpful to look for etiology of the disease and look for things to treat. LFT is useful to ensure there's no biliary ductal obstruction. Fecal elastase is a good test to order because it's a better way to look for exocrine pancreatic insufficiency. In addition to the clinical history describing steatorrhea, but the clinical history is not as reliable or as sensitive. Transabdominal ultrasound is a good place to start to help identify a patient that has signs of chronic pancreatitis. Endoscopic ultrasound can help visualize the pancreas and the pancreatic duct a little better. It can also biopsy the pancreas, which can help elucidate the etiology. CT and in particular MRI are helpful in visualizing the pancreatic duct and see if there is a divisum, which can also be a source of the chronic pancreatitis. So, imaging findings. Hyperechogenicity on ultrasound signifies fibrosis. You can also see shadowing calcifications on the ultrasound. CT can show calcifications as well. It can show pancreatic ductal dilation and also gland atrophy. MRI shows low signal intensity on T1 weighted imaging as well as delayed enhancement after IV contrast injection. It will also show gland atrophy. Can see abnormalities in the pancreatic duct as well. This includes a pancreatic divisum and a chain of lengths appearance from calcifications in the pancreatic duct. Of note, you can also administer secretin, which will have a delayed and decreased response by the pancreas in patients with chronic pancreatitis. This is a functional imaging modality of the pancreas. Treatment for these patients is mostly symptomatic control. Again, celiac plexus blocks can be performed to help relieve the patient's abdominal pain. This is accomplished by an endoscopic ultrasound and injecting local anesthetic into the celiac plexus. This typically lasts for weeks, but can significantly help patients reduce the amount of pain medications they are on. As with all other types of pancreatitis, nutritional support is of the utmost importance. Some patients develop early satiety or significant nausea and vomiting, and therefore require tube feeds administered either via nasojejunal feeding tube or percutaneous endoscopic gastrostomy tubes with jejunal extensions, or even operatively placed jejunal feeding tubes. Following patients' nutritional labs is important to ensure their nutrition is adequate. In addition, many of these patients require pancreatic enzyme supplementation. Things to keep in mind for this is that if a patient has steatorrhea, they have pretty significant exocrine pancreatic insufficiency and should be started on enzymes. A fecal elastase can be checked to help confirm the diagnosis. Patients should be educated on the correct way to take pancreatic enzymes. Because of their short half-life, they should be taken immediately before a meal and sometimes are needed again halfway through the meal. If they forget to take the pills with the meal, they should not bother taking the pills afterwards because it does not do them any good. Patients should also be placed on a proton pump inhibitor or some other antacid medication because acid degrades the enzymes quicker. Therefore, decreasing some of the acid production in the stomach can help the enzymes function better. Lastly, patients dealing with chronic pain need to be managed, supported mentally. In this day and age of the opioid epidemic, patients need to be educated on the adverse effects of chronic opioid use. This mental support can include psychological support to help them cope with their disease, as well as help them develop methods to reduce the amount of pain they are in and get them off of the chronic opioids. Patients with chronic pain can develop centralized pain as opposed to visceral pain. In these types of patients, psychological support is of the utmost importance to help wean them off of the chronic narcotics and help them get to a better quality of life. In severe cases of chronic pancreatitis that are causing significant abdominal pain, surgical options may be necessary. It's important to rule out central pain syndrome because operating on the pancreas will not help this type of pain. Operative indications are chronic visceral pain as well as patients that are having recurrent acute pancreatitis. The operative interventions can be broken down into two categories: drainage procedures and resection procedures. Sometimes both need to be performed. Drainage procedures are performed if there is duct obstruction causing duct dilation. The dilation of the duct can be painful and therefore filleting open the duct and sewing it to a loop of bowel to allow it to drain will help. This will also help with the patient's exocrine pancreatic insufficiency. Chronic pancreatitis causes calcifications to form as well, and therefore sometimes debridement of these calcifications allows the duct to drain. There are endoscopic options as well, such as ERCP with pancreatic duct stent placement. This is not a good long-term option as the stents tend to fall out and not stay in long-term, but they can provide valuable information. For example, if they help with the patient's pain, then you can be more certain that they would benefit from an operation. This is particularly important in patients with pancreatic divisum, and that if the minor duct is stented and their pain is improved, or their episodes of pancreatitis are reduced, then you can be more confident that an operation will help them. We're going to talk about the various drainage procedures and resection procedures. So first, we're going to talk about the Bager versus the Frey versus the burn. So these are duodenum-preserving pancreatic head resections. The Bager is where you resect the head and sew the jejunum to the pancreatic head stump and the neck of the pancreas. This is for isolated pancreatic head disease. The Frey was developed where the pancreatic head is debrided and opened up, and the pancreatic duct is opened up along its length, and a pancreatic jejunostomy is then fashioned. Lastly, the burn was then described where the pancreatic head is debrided and a loop of jejunum is sewn to the open pancreatic duct in the head, where the body and tail duct is left alone. Drainage procedures for the body and tail of the pancreas involve the Duval, the Pusteaux, and the Partington-Rochelle. The Duval includes a distal pancreatectomy and splenectomy with the end-to-end pancreatic jejunostomy. This is for small pancreatic duct that can dunk the end of the pancreas into the loop of jejunum to help it drain instead of sewing the jejunum directly to the side of the small duct, which is technically difficult and likely to stricture. The Pusteaux is an operation that is rarely performed anymore, but requires a dilated pancreatic duct that is opened and sewn to the jejunum. It's a modification of the Duval. The Partington-Rochelle is a lateral pancreatic jejunostomy. This is the most commonly performed operation compared to the Duval or the Pusteaux because it preserves the most amount of pancreas while draining the pancreatic duct. These operations are performed when patients have no disease in the head of the pancreas or when they have stones in the pancreatic duct in the head that are causing dilation in the body and tail that when decompressed will relieve the entire backup of pancreatic fluid. When performing the Partington-Rochelle operation, the dilated duct is identified by sticking a needle into the pancreas until pancreatic fluid is returned, and then cutting down on the needle to enter the duct. The duct is then followed and opened up along its length. An intraoperative ultrasound can also be utilized to help identify the main pancreatic duct. I'm not going to discuss the pancreatic duodenectomy, central pancreatectomy, or distal pancreatectomy. The only resection procedure that I'm going to discuss now is the total pancreatectomy with islet cell autotransplantation. Of note, the other resection procedures can all be performed with islet cell autotransplantation as well, but the islet cell yield is not as high. The total pancreatectomy is most commonly performed islet cell autotransplantation procedure. At our institution, the patient is required to go through a large multidisciplinary workup that ensures this big operation is being performed for the right reason. Seeing as these procedures are mostly for pain relief, we have patients see pain medicine as well as pain psychology. We also have patients get a differential pain block to help determine if the pain is centralized or visceral. Endocrinology is involved, as well as surgery and gastroenterology, and they are presented at weekly multidisciplinary conferences. In the operating room, the entire pancreas is resected with or without the spleen. The pancreas is then shipped off to a lab where it is processed and spun down to isolate the islet cells. The islet cells are then shipped back in bags, and the islet cells are infused into the portal vein via the splenic vein if the spleen is removed, or the inferior mesenteric vein if the spleen is preserved. Literature out of the University of Minnesota shows that the long-term outcomes are approximately 1/3 of the patients are insulin independent, 1/3 of the patients require some insulin, but their blood sugars are well controlled, and 1/3 are brittle diabetics. That being said, if the islet cell yield is greater than 500,000, then the patients tend to have better outcomes. Of note, postoperatively, the patients require long-term pancreatic enzyme supplementation for the rest of their lives. And also, if cancer is suspected in these individuals, then the islet cells cannot be autotransplanted. This concludes my talk on benign disorders of the pancreas, focusing on pancreatitis. I hope you learned something. Thank you.